So hello and welcome to this ARMA webinar on services for people with musculoskeletal conditions for the fitness and leisure services. ARMA webinars are free to access thanks to our partners, and we'd like to thank Good Boost for sponsoring this webinar. My name is Sue Brown and I'm the Chief Executive of the Arthritis and Musculoskeletal Alliance, ARMA. We're an umbrella body that brings together patient and professional groups to work for better health services for people with conditions like arthritis and back pain. This is the second of two webinars aimed at your industry. The first one gave an introduction to musculoskeletal conditions and why being active is so important for prevention and for managing these conditions. Today, we're going to be hearing about two programs which can be delivered in leisure facilities. Both speakers are going to give a brief outline of how their program works and the costs and the business case. Before I introduce our speakers, I'm aware that we are all very familiar with the way that health services work in the UK, and some of you may not be. So I'm just going to very quickly run through one or two of the things you might need to be aware of and jargon that you may hear during the presentations. So the first one is, I believe at least one of our presenters will make reference to clinical commissioning groups or CCGs. These are the bodies that plan and commission healthcare services for their local area. So that's NHS health services. They're made up of GP practices, and there's around 190 odd of them in England at the moment. And they represent about 60% of NHS spend. That is for England. I know we have some people joining us from other nations, and obviously the system there is different. The second thing to mention is public health. So that's about the prevention of ill health. So public health does things like smoking cessation, and increasingly they do prevention of musculoskeletal conditions. Public Health England has a programme around musculoskeletal conditions. Public health is led by local authorities rather than the NHS. And then finally, I want to mention social prescribing link workers. So link workers are there to connect people to community groups and local services for practical and emotional support with their long-term conditions. They are being employed within GP practices, and in England, and NHS England is aiming for there to be 1,000 in post by April and 5,000 over the next 5 years. This is a group of people who, if you are going to do something specifically for people with any long-term condition, will be interested to know about it. If you're going to implement any program, including the two that you're hearing about today, or indeed just pick up on some of the things from webinar number one, make sure that your link workers know about it. Their job is partly to know what's going on in their local community, so you'll be helping them do their job. They're also linked into primary care teams, so that is a way of making sure that practice nurses, GPs, receptionists also know about the services you might be offering. And finally, I've put there the link to the page on the ARMA website where you will find recordings to the first of these webinars, and once we have it posted, the recording to this webinar as well. So without further ado, I'm going to stop sharing that and hand over to Ben Wilkins from Good Boost to explain what Good Boost is and how it works. And you're still on mute, Ben.
Fantastic. Right, I'm going to share screen now. Brilliant. Hello, good afternoon, everyone. I'm Ben. I am founder and CEO of Good Boost. I am a MSK clinical champion for Versa arthritis, and my background was I trained as an osteopath before going into research where I published some papers while at Oxford, focusing on aquatic rehabilitation for MSK conditions, as well as community-based community MSK conditions. So Good Boost was set up about 3 years ago, and I'm going to take you through what we do and how we deliver it. So Good Boost set up because of the size of the problem. So we know that MSK conditions has a huge impact on society and people's lives, with almost 18 million people living with an MSK condition. It counts around 2 in 5 GP appointments and a price tag for the NHS of about £5 billion. We know that a big slice of MSK are things like hip and knee surgeries. We have over 200,000 hip and knee replacements every year in the UK. Some of the projections project that to increase from 100 to 600% in the next 15 years, and that's going to be a real challenge for services to deal with. What we know from research is that things like hip and knee replacements, so primarily caused by arthritis and osteoarthritis, can be preventable and they can be delayed. And we know that physical activity can do that really effectively, not only to delay or avoid surgery, but also to improve the outcomes post-surgery. So we know all this stuff, and we know exercise works, but the real challenge is that it's not a knowledge deficit, it's a behaviour deficit. Loads of people now know that physical activity is good for their health and good for the MSK health. So it's not a deficit of knowledge, it's a deficit of behaviour. Quite often because being active with an MSK condition has many barriers: pain, multimorbidity, fear. There's limited attendance and adherence because of low motivation. As people get older, there's more inactivity. And because of a limited number of physios, it means having well-staffed community services is a real challenge for the growing demands. So we looked at, as a team, how we could look at better ways to deliver community MSK services where there may not be a healthcare professional always present. We looked at the published evidence on the use of aquatic rehabilitation and exercise for a wide range of MSK conditions. And we know that our partners, such as Swim England, have published reports highlighting that aquatic activity reduces pain, improves function, improves quality of life, that reflects this finding in all the studies you see in front of us. So we know that published research demonstrates that aquatic activity was highly effective for MSK conditions. So we know that for things like hip and knee joint replacement, hip and knee osteoarthritis, MSK conditions, balance, rheumatoid arthritis, that aquatic activity has strong evidence behind it to show its effectiveness. So that's what we focus on at Good Boost in terms of how we develop and design our programs using artificial intelligence. So what we designed and developed as a team of clinicians, researchers and engineers is a rehabilitation app that uses digital clinical thinking to deliver individually tailored rehabilitation exercises in water on a waterproof tablet. And what it looks like for our users is they'll go into a leisure centre, they'll be provided with a waterproof tablet, and they'll complete an assessment. That assessment is like a clinical consultation. That information goes into our AI decision-making engine, and from that, it will then make recommendations on what's the most appropriate exercises for that person based on their condition, their ability, their diagnosis. Each user will then take a waterproof tablet into the water, and to go either as an individual when it works for them or during a group session. They'll follow those exercises on the tablet, and with the feedback they provide to us, that provides us with more information, and it goes back into the engine to again adapt and evolve their program session to session as they come bespoke to them. So what we've created is individually tailored exercise selection by artificial intelligence, and we're on today at Microsoft because Good Boost is part of the Microsoft AI for Good program. It's been designed by both MSK and aquatic experts, where we train staff and volunteers in leisure centres to become facilitators for Good Boost sessions, both for individual and for group sessions. We know we improve pain, function and quality of life, and it means it's a low cost and accessible way to deliver musculoskeletal services. Importantly, is measurable impact. As I mentioned, we're a team of researchers, clinicians, engineers, and tracking things is really important to us. And we're able to measure the change in every single participant because it's like an ongoing clinical trial because we collect baseline information and follow-up information every 4 weeks. Some of our key achievements is we're registered as a Class 1 medical device with the Medicines and Health Regulatory Authority. We've completed the clinical audit review by the Aquatic Therapy Association of Chartered Physiotherapists to look at our safety, suitability and optimization of our exercises. We're a core partner of Swim England as part of their water wellbeing strategy, and we're an approved training centre with active trainers, facilitators as those members of staff and volunteers.
Every single person who comes to the class gets a little iPad, and they have some structured exercises in which you just work through yourself. Just the benefit of being able to do exercise when anything apart from walking is difficult.
I've got arthritis, and the exercises do me a lot of good.
I've had problems with my knees for a long time, and knowing that I had a knee operation coming up, I decided to start doing some hydrotherapy.
Unfortunately, I've had already 3 new knees, so my walking is not that great. My balance isn't good. I feel fitter. I get the feeling I want to get up, in the morning.
Everybody's really friendly. We're all in the same boat. We've all got some kind of problem, but it doesn't matter. I enjoy the exercises, but most of all, I think I enjoy the company.
And that was a little overview of some of our sessions and some feedback. But what's really important, as we've learned over time, is that we've got some really cool technology, but it's so much more than technology. What Good Boost enables is that a group of people can follow their exercises, but also then go and have a chat with each other, learn about each other, and it creates natural and organic peer support peer support networks within those participants who go along, because it's individual, adaptable, social, and fun. And by working in water, we get around those barriers you normally get on land. Pain, multi-morbidity, fear, things that can really prevent people. But you can see in one of the images here, the people come along with their walking aids and strollers straight to the pool site and get in, but they can move in ways not possible on land. So I'm going to share with you some of our data and outcomes from our NSK technology funded program in 2019. So our average age was 57, but the mid spread of data was between 42 and 71. On average, our users were overweight to obese. We had 340 people come through. We had a really high ratio of men, which were in aqua aerobics. There's normally not so many men that join in. And 1/5 of our participants were from the lowest income households, showing that we were cutting through inequality. So on average, people had 2 additional long-term health conditions in addition to the MSK condition, which is quite reflective of the MSK population, most notably heart conditions, diabetes, other cardiovascular problems. 1/3 of our participants said their walking mobility was less than 100 meters. And this has been really important to us because these are individuals who wouldn't be able to join a walking group. And quite often the low-hanging fruit of physical activity options is usually to join a local walking group. And that 2/3 of our participants were physically inactive, as scored by the Sporting and Active Lives questionnaire. So we're getting people who normally wouldn't be active to start being active. But being in water wasn't a barrier, because 41% of our participants either said they were non-swimmers, very low confidence swimmers, or low confidence swimmers. And the way we use that within our AI is to make sure they are recommended exercises that's appropriate to their water confidence level. And importantly, it meant 49% of people were brand new customers to that leisure centre, coming through referrals from GPs, social prescribers, so adverts. So it's a brand new customer group for that leisure centre. And what we saw improvements in pain, function, and overall quality of life through participants engaging in the process over multiple weeks. And what we do is provide every single pool with a monthly dashboard so they can track their progress, and also they can then share that with their local funders, whether it's local health, public health, NHS, or local authority, to demonstrate that they are delivering a tangible community MSK service. And from our existing pools, that's something they see is really valuable. So at the moment, we've been funded, and we're currently been scaling up throughout the country. We'll be in over 50 pools by June this year. And what we're a plug-and-play solution that we can deliver our tablets computer within our charging station, connect to Wi-Fi, and it's ready to go. We can train volunteers, we can train receptionists. You don't need to be a level 4 exercise instructor to deliver Good Boost. And we're really excited because we've trained a few volunteers who live with an MSK condition, and part of my background was in peer-led MSK services. So we're really looking forward to how people living with MSK conditions can support other people to be active too. What it looks like is through social media, leaflets, social prescribers, GPs referring in, or people self-referring into the leisure centre. People complete that registration when they arrive. They join a group, and it means that they can continue tracking their progress, and that gives them motivation to keep going. But that's kind of the very simple overview of how it works. People coming from outside in to be brand new customers, and then repeated attendance over time to see those MSK improvements. And this is what it looked like. So for that new participant on the top stream, they'll arrive around 30 to 40 minutes before a class. They'll complete their registration either by an instructor or by a receptionist. They'll then join a group class and they'll take part within 30 to 60 minutes. And then they'll hand the tablet back at the end. And then once they're an existing participant, they can then arrive 10 minutes before the session. They can either join in with that group session led by a facilitator, or they can hire a tablet just like hiring a badminton racket and go in to complete an individual session by themselves or with a friend. But it means pools can utilize that time of the day where actually there isn't time to have a group session, but during public swim times that can be better used in the evenings and early mornings. We've been completing a business case, and this will be sent round at the end of it to make sure that it's also financially sustainable for leisure centres. At the moment, we just about break even for leisure centres, and we're really happy with that. Where we're changing is this year we're adding in aquanatal programs for expectant mums, sports conditioning and exercise, and those additions mean that there'll be more customers to take part in those additional programs, and that's where we really see a financial benefit to leisure centres. Not only to deliver sorry. Sorry about that. Not only to deliver a health service, but also one that makes financial sense for the leisure centre.
And so I was looking for something to do because I couldn't do any exercise on land. It's taken me 5 years to find some exercise I can do, and it's made a heck of a difference. I can now use my left leg to step up occasionally, and I could not do that before because if I tried to put weight on that to step up, it just collapsed. I'm on my own, I can do something on my own.
I've had a back condition since I was a child, AS, ankylosing spondylitis. I've been looking for some way to keep active, and these sessions are a great boon, they really are. The consequence of it is I've managed to reduce the drugs I'm on and continue to do that, which is really good. The other thing is I can sleep. By doing the exercises, I can actually get a good night's sleep and at the same time reduce the amount of drugs. It's a winner all the way around.
So that's all of me. So yeah, what we do is we enable swimming pools to be better used, not only to deliver health services, but also make sure it's financially sustainable long term for the pools to run that. If you wanted more information, there are my details, or you can get, and the presentation will be sent around at the end of the session. I'll hand back over to Sue now. Thank you all very much. I think you're on mute still, Sue.
Thank you very much, Ben. And we are going to take the next presentation from Mike before we take questions, but please do pop any questions you have for Ben in the Q&A box, and we'll come to that at the end of the webinar. But now I want to hand over to Mike Hurley from Kate Paine, which is a very different intervention, but along attempting to achieve similar outcomes. Mike.
Hi, so I hope you can hear me. I had some problems. I had to change rooms halfway through Ben's presentation, but hopefully a bit more stable now. Right, let me bring those up. Okay. Our program's called Escape Pain. It stands for Enabling Self-Management and Coping with Arthritic Pain Through Exercises, and has concentrated so far on older people with hip and knee pain. Ben's sort of quite nicely made this slide redundant in many ways. It's really showing the size of the problem here in the UK. 10 million people with this problem, and it gets worse as people get older, the incidence and prevalence of it. It's getting worse also because we're living longer, but doing less and less of everything apart from eating more and more, which are risk factors for developing chronic hip and knee pain. It's an enormous problem to the people, causing them pain, decreasing their mobility and function. 1 in 5 primary care consultations, and if you are fortunate enough to get one, you are likely to be managed with drugs rather than what people should be getting: advice, information about their problem and how they can help themselves. And that's really where Escape Pain comes in. It's a rehabilitation program where people attend in groups of about 10 people twice a week for 6 weeks. Each of those 12 sessions, they get about 20 minutes of a themed discussion really about their problem. what causes it, how they can help themselves, and particularly stressing the importance of physical activity. And then they get about 40 minutes or so of a supervised exercise regimen where they are, it's individualized to each person in the group, but they're challenged, each of them, to kind of nudge the barriers and boundaries of what they can do, so that they can actually start to do more over the course of the 6 weeks. It shows people what they can do. It starts to alter their symptoms, obviously making their pain less, and the fact that they can do more. And in doing that, they experience those benefits. They start to change their beliefs about their problem and about how physical activity in particular can actually be used by them to help themselves. They start to change their behaviours, particularly becoming more physically active. And in doing so, that changes the whole course of the condition. We got an email from someone the other day that summed it up better than I have in 20 years in many ways. They say that we'll be challenged when we start to push the programme around the country, that there are other programmes out there that meet nice guidelines. And she said her argument was that this is better. It's far broader than simple exercises. It takes a psychosocial model of managing chronic joint pain, and that we're looking to change behaviours permanently. And that can't be done in 3 or 4 classes. And it's exactly what Escape Paine is trying to do, change people's behaviours. We've got a wealth of data to show that the programme is safe, effective, reduces healthcare, is more cost effective than what's out there at the moment. We know that the participants and also the therapists who deliver it like it, and we can sustain the benefits for up to 30 years. And it may help people avoid surgery, which is often seen as one of the only ways of treating this problem. The problem is, when we were pushing it through the NHS, is that we have a very large population of people trying to access very limited resources. So we decided why keep this inside in the NHS? This could be delivered in leisure centres. And then after a pilot study which showed that the programme was effective out there and could be delivered and replicate the outcomes, we got a grant from Sport England and Versus Arthritis to work with leisure companies up and down the UK to see if we can actually push the programme out into the leisure community sector and see if we can increase access to people and improve the lives of many millions of people. One of the first things that we did was to develop a training programme that we got accredited by REPS and SimSpa, so that the trainers were confident in delivering the programme for us to older people who had hip and knee pain. And as we've gone along, we've shown that actually the outcomes are exactly the same if you deliver this in leisure or community venues as in clinical departments. There's virtually no difference in the outcomes that we're achieving. With the Sport England, it was slightly different to how we normally deliver Escape Paine. We were looking at older people who were very inactive. And when we looked at the people that we were recruiting, we were finding that we were getting an age range from 55 years and over. But 30% of the people coming on the study were over 75 years of age. So you can engage older people on what is a burdensome programme, really. They are keen to become involved. We're also looking at their physical activity, those who were classified as inactive, so doing less than 30 minutes a week, and how the programme would affect it. And you can see that beforehand, the vast majority of people would be classified as inactive. But as they go through the programme, and then subsequently in the 9 months or 12 months after that, you can see that we were changing people from being inactive into actually people who were active. And that this was being maintained, even though the programme was finishing after 6 weeks. And at the end of that, we were also asking people what they were planning to do. Most of them intended to continue being active and indeed taking up new activities. What tended to interrupt them was that there was painful flares, illness or injury, but we had instilled in them an interest in activity and engagement in activity. And when we asked them what they thought about the whole programme, they said they enjoyed it, they understood their problems more, they felt more informed, they found the benefits of the programme, both physical, mental and psychological. And it gave them something that they could use to self-manage themselves. And on our website, there's lots now of videos of participants and their feedback from it. But here's a kind of range, and it shows you that, yes, people do say that they benefit in less pain and being able to do more. But like some of Ben's participants, it was the wider benefits of exercise that they also mostly enthusiastic about, that they can sleep better, they can play with their grandchildren, they can put their shoes and socks on. The simple things that make our everyday life livable, really. And that it was something that they could do for the rest of their lives. They were walking with a stick, they were taking less pain. And they're also very much more engaged with physical activity. Here's some quotes from them. The fact that the exercise was becoming part of their everyday life, becoming habitualized by them. And they were seeing that the leisure centre where they were doing the activities now was somewhere that they felt much more comfortable with. And some of the organisations had laid on taster sessions for them so that they could join into yoga classes, Tai Chi classes, etc. And it didn't stop them from having to attend hospital these days. The organisations, when we asked them how they felt about the programme, were very pleased with it by and large. It complemented their ethos and their plans and their offers. They can see what's coming down the pipeline from the NHS as things has been pushed out of hospitals into the community. Their main concern was how they would cover the costs going forward to sustain the programme in some way. And those costs can vary from, they were reporting to us, £246 up to about £600 to cover staffing, hire of the venue, marketing, participant booklets, etc. And the ways they were looking at those was to sustain the funding was maybe through CCGs, if they had good relationships with them, or by charging for the classes or post-escape pain classes that people could be appointed to afterwards. The participant charges that they were saying was that some of them were providing it free, and some of them were saying, well, we've taken a view here from a business point of view that we'll take a hit at the start with a view to actually sustaining something in the long term that we can certainly start to make a revenue from. Some of them were using pay what you could afford kind of strategies. And those need subsidising. And again, there are CCGs in some areas we know who are delivering it free to deprived areas, but charging in affluent neighbourhoods nearby, so that they were kind of cross-subsidising really. There was partial costs were recouped through additional revenues from memberships, additional classes that the participants would pay for, food, coffees, etc. And again, CCGs sometimes willing to part fund that, or indeed public health departments. And some people were having to pay the full cost of the course, but what was being offered to them was reduced membership or redeemable cost of the membership at the end of the course if they had doing that. And more now we're finding that CCGs are starting to think about how people can actually engage with the leisure sector to provide the programme outside hospitals. And just before I came in here, I got an email saying that the King's Fund was showing how CCGs were starting to think much more broadly now about what they are commissioning and how they will commission those. If you're going to commit to commissioners, you have to get good evidence to show that what they are commissioning works, which is fair enough. We know some places are co-delivering it with clinical departments to alleviate the pressures on physiotherapy or orthopaedic wait lists, improve the appropriateness of people being referred for surgery, and actually also post-surgical outcomes. You have to show them it saves money. At the end of the day, we're all under great financial pressure these days, but it can save money in terms of reduced consultations, medication, investigations, and interventions. In our original trial, we showed that for every pound invested in through the health system, there's a return of £5.20 back. We've put some recent numbers into the community venues, and it shows that if you deliver escape pain through the community venues, for every pound that's invested, you get £8.80 back. It's also the feedback we're getting that it addresses the concerns that people have now about the problem with opioids. And for CCGs, it's resonating with the, as I say, the kind of direction of travel for the NHS. That's to provide integrated care in people's communities so they can self-manage themselves better, break down social isolation, increase social prescribing out there so we can use the great things that are happening out there and prevent these problems from arising. And it can happen. We know CCGs are becoming involved. We know one area where there is a 1-year pilot of delivering escape pain outside hospitals and the leisure centres. If that's successful, they're hoping for a 3-year contract. If not, they're not going to stop escape pain. They're going to charge for it. We help people as much as we can. We have apps. We have a great website where people can go and find out about it. It's been badged up and endorsed by the good and the great. And we are here as a team here at the Health Innovation Network to help people implement it as much as we can with toolkits, a synopsis of the evidence, building business cases for CCGs, etc. And over the past 5 years, this has been the spread of escape pain. It's now in 278 sites. 46 of those are outside hospitals. We've got over 1,100 people trained to facilitate the program. Nearly 18,000 people, as an actual fact, have gone through this now, and we reckon that we're saving the health systems about £26 billion. So a win all round, I would say, for everybody. This year, we've been started to pilot escape pain for backs here in London, where we can keep a close eye on it. But there's a great deal of interest in it, so we are rolling it out through hospital departments now outside London, and we're hoping to roll it out through the leisure and community venues towards the end of the year. So again, another massive population of people who hopefully will benefit from this. There's a lot that we can help you with. There's the team that will help you on the occasion of my 200th birthday. I certainly look at it in that photograph there. Go on our website and see lot more information about us. You can contact us on hello@Escape Pain. But we're there to help you as much as you can. And if you want to know more, we've also got a conference coming up here in London on March the 24th, where some of the people are going to be explaining the actual business cases and their experience with escape pain. It's free. It's opening up, I think, today for registration generally. So please come on our website, find out where it is, and we look forward to seeing you on the 24th of March. Sue, thank you.
Brilliant, thank you very much. And we will include a link to that sign up in the email that you should receive probably on Monday after this webinar, which will include a link to this recording, a link to the page where you can find the recording of the previous one. So yeah, thank you both very much. And do pop any questions that you have for either presenter in the Q&A box. So I think Ben's directly answered a couple, but maybe it's worth having a bit of a discussion about those. So there was a question about whether Good Boost had received financial support from CCGs or public health to fund it. So I believe Escape Pain has in some areas, hasn't it, Mike?
That's a better one for Mike to answer, because Mike's had much more direct funding than we have.
We have, as I said in the slide, there are some CCGs that are forward-looking enough to join in, both funding through the clinical departments, obviously, which they're much more comfortable with, but now increasingly thinking about outside hospitals, so the leisure and community sector. So it's coming. It does need, progressive, forward-looking CCGs. It's very difficult to engage with them. It's even more difficult to get money out of them. But it's happening, and they are beginning to realise the benefits of getting out and delivering these kind of interventions, Escape Pain and Good Boost, in the community.
And I would say that Escape Pain has been around for quite some time, whereas Good Boost is fairly new. So I suspect that Good Boost will be getting more interest from CCGs as you begin to roll out.
Yeah, I mean, we hope so. So we've been supported with 2 pools in London who have been supported with funding from the Healthy London Partnership, which is a combination of the Department of Work and Pensions and Public Health. They're our first examples. We're hoping for more, but we know that leisure centres we're currently working with are starting to make business cases to go and present to Public Health, to go and present to CCGs, because we've supported them with those bids.
Great. We've just had a question about what you see as the main barrier to the spread of Good Boost. Any thoughts on that?
That's a really good question. At the moment, we're in a really good trajectory. We've been supported with a good amount of funding to grow, develop our technology. What we've done is we've hit a real niche in that we work exclusively in water, and a lot of swimming pools don't know how to best use that space to provide health services. So I think one of the biggest barriers is that for leisure centres, they don't generally have a budget for the pool. All their budget goes into plant and facilities and everything else. But for actual activities that go in the pool, historically there isn't a budget, because they buy their noodles, they buy their aqua aerobics equipment, but then after that there's no real products to buy in, so there is no budget line. So that's been the biggest challenge we have, because within a normal leisure centre, buying a £5,000 exercise bike is the norm. It's completely standard. But to set us up in the first year is to buy the waterproof tablets that we build, pre-install, and then after that is the monthly ongoing license fee. And when you compare it to any of our exercise equipment, it's cheaper on average. But because there wasn't historically a budget line in the swimming pool for that kind of equipment, that's where we've had to kind of have those conversations early to make sure in the next financial year there is that budget line. I guess that's been the biggest thing to slow us down so far.
So for anyone watching this who's thinking, yeah, this would be a great thing for us to deliver, as a tip, start talking about budget to whoever holds your budget setting powers now. Mike, have you got anything to say about the spread of escape pain? Because it is beginning to take off in a big way now, but it took a while to get going, didn't it?
It does, yeah. It takes a while to get momentum behind it, and it's really taken off since the Academic Health Science Networks adopted it for national rollout, which our 2-year grant, if you like, from that is coming to an end, and also Sport England getting behind it. So having bodies like NHS England, Sport England behind it have been a real boost for us, good boost for us. I think our problems are similar to Ben's in some ways. I mean, getting this thing commissioned and sustained is always a problem out there. Getting beyond that, if you look beyond that, I think convincing people sometimes to go to leisure centres when they have health problems is something that we have to overcome, because people in England, reliant on the NHS, kind of think, well, if I need an intervention, I have to go to a hospital to get it. To convince them actually there are other opportunities outside hospital is a kind of getting over that mindset in some ways. We have lots of pushback from clinical departments that are already saying, well, we're running something very similar to this, but we do it with 3 or 4 sessions. Why do you need 12? And as I showed you in one of the quotes from one of our supporters out there, if you want to get people to change their behaviours long term, it needs an intensive input, I suppose you would call it. So you have to have a kind of short-term investment to actually start to get your long-term gains, and getting over all those kind of arguments against it. Why do we need this? Is one of the things that we're always having to explain and help people to overcome.
Okay, great. So we had another question that I think Ben did answer on kind of online, which is around the demographics engaging with, in this case, the swimming initiative. Is the population centred around white, middle class and relatively wealthy people? And how can we be more inclusive? And I think that's a really important question actually for both of you, because we know that the incidence of musculoskeletal conditions and musculoskeletal pain is greatest in areas of greatest deprivation. So I don't know if either of you want to comment on how you can make sure that this is accessible to the people who most need it.
Yeah, I'm happy to start. Yeah, but first of all, I want to echo what Mike said about Mike and I share a lot of the same frustrations around behaviour change and financing, and even though it's Kate Paine's on land and we're on water, those are some of the key barriers that Mike highlighted. In terms of inclusivity, in terms of income and ethnicity, so what we know from the demographic stats from Good Boost, we know that actually we're quite reflective of the general population in terms of Caucasian, non-Caucasian, Black, Asian communities who take up Good Boost. Which we weren't sure if we were expecting. I know that some of my research applications, funding applications were thrown out a few years ago because the argument was that swimming was a white middle class activity and therefore wasn't an inclusive activity. But actually we've debunked that at Good Boost. We've shown that we have a reflective population that attends Good Boost, the same as the makeup as the UK. What's been really interesting is that in our 2019 funded programme in the MSK Technology Fund, the vast majority of our pools were in middle to high income areas, but still a fifth of our participants came from low income households, from the 30% lowest income house in the UK. And what that showed was that people saw value in what we do. They were willing to travel to it. They were willing to pay their £4, £5, £6 to attend because they saw it as a valuable service. What we're doing now going forward is we've just selected our next 40 pools of Swim England, where we're going to be launching from May to June this year. And over 90% of those pools are in areas where they're either immediately in neighbourhoods or adjacent to neighbourhoods, again in the 30% lowest income areas. And the reason we did that was because we went to our funder and said that we want to cut through inequality, and we believe the reason we can get even more than go from a fifth of participants to a third to maybe half of our participants from low-income backgrounds if we're at pools in low-income areas, because transport and travel is a traditional barrier to activity. But it's the same for Kate Paine in terms of the biggest challenge we have in behaviour is friction. Wherever there is the greatest friction will mean that people will find any excuse not to go along. So whether it's Kate Paine, a Zumba class, Good Boost is about cutting through anything that can cause friction, from price, transport, time of day. They're the key things that stop it.
Yeah. In terms of inclusivity, I mean, you know, there are no boundaries, you know, to this. We've been lucky enough to be backed up by Versus Arthritis, Sport England, NHS England, and all those people have at their forefront, you know, is this equitable? You know, we don't want any barriers here, you know, in terms of, you know, ethnic groups or whatever. And we've been lucky enough to be able to actually engage with people in Liverpool. There's a fantastic company called Healthiness up there in inner city Liverpool, Toxteth, who run it for their local population brilliantly. In northwest London, they ran the class delivered by Gujarati speakers to their local population, ran brilliantly there for a while. We've actually had it translated into Welsh as well. I'm not saying they're an ethnic minority, but it shows that there are no barriers here. We deliver it in inner cities, we deliver it in rural areas. Each of those have their own sort of particular problems. But I would say that there isn't an area that we've come up against yet where we haven't been able to overcome those and help people deliver the program. You know, it's a very flexible program. It makes sense to people who are running it, and once people see the benefits of it, then, you know, they become really keen on it. For us, it's those aren't great barriers. It's more the kind of funding of it, the commissioning of it, are the real barriers.
Okay, great. And we've got one last question in the Q&A box, which I'm not sure if either of you will know an answer to, but we'll give it a go. If not, I will try and find an answer and contact you direct afterwards, which is this: is there a level 4 or 5 qualification you would recommend for exercise professionals to upskill? I'm very familiar with the level 3 exercise referral, but I'm after something more in depth. Now, it may be that neither of you is the right person to answer that, but if either of you know it off the top of your head, otherwise I will try and track down an answer. And
I know that Swim England are doing their aquatic activity for health program, which I think is a level 4 equivalent, and you need to be, I think, level 3 trained already, but that's specific to one-on-one support for people with a range of long-term health conditions and water. But that's all I can really help with, that's all I know.
Okay.
I wouldn't be able to help either. To deliver as Kate Paine, our exercise professionals have to be level 3 qualified, but I'm afraid I don't know after level 4 or 5. I'm sure there are ways to find out. Okay,
I'll endeavour to find an answer to that question and include it in the email on Monday. I think we have 1 or 2 ARMA members who may be able to help us with that. So if there are no more questions, then I'd just like to thank you all for joining the webinar. I hope you found it useful, and thank Ben and Mike for sharing their experiences of running these 2 programs. The recording will be available online, and you will all get a link to it and how to access the first webinar in case you missed it. Please feel free to share that.